In the simulated oral examination environment of the surgical boards, the examiner presents you with raw clinical data, and you must vocalize a precise algorithm to keep the hypothetical patient alive. The examiner opens with a trauma call. An 18-year-old girl has fallen from a horse, suffering a direct kick from the animal during her descent. Upon arrival in the resuscitation room, she complains of generalized abdominal pain, accompanied by a very specific, sharp pain at the tip of her left shoulder. Her initial vital signs indicate hemorrhagic shock. Her blood pressure is 84/60 millimeters of mercury, and her heart rate is elevated at 110 beats per minute. There are a few reassuring metrics. Her chest examination is normal. Her oxygen saturation is 100% on 24. Your immediate required response as a candidate is to explicitly state that you will follow the Advanced Trauma Life Support, or ATLS, primary survey guidelines. You acknowledge that her airway and breathing, the A and B of the algorithm, are intact. That dictates an immediate pivot to C, circulation and hemorrhage control. You order your first major therapeutic intervention, the rapid administration of 2 liters of intravenous crystalloid fluids to restore intravascular volume. In any blunt trauma scenario, confirming the ABCs and initiating immediate volume resuscitation always takes precedence over diagnostic imaging. You secure the physiology before you hunt for the anatomy. With the fluids running, you proceed to the secondary physical findings. The abdominal examination reveals a visible abrasion located just beneath the left costal margin. Palpation elicits tenderness localized entirely to the left upper quadrant. Geographically, this points directly to a potential injury of the spleen. This localizes the cause of her seemingly unrelated left shoulder tip pain. Clinically, this referred pain is known as Kerr sign. Kerr sign occurs when free intraperitoneal blood pools under and irritates the diaphragm. Because the diaphragm and the shoulder share the same embryonic origin, the pain signal travels up the phrenic nerve and is perceived at the shoulder. Following the 2-liter fluid challenge, the examiner provides an update. The patient's blood pressure normalizes to 130/90. This specific physiological state is transient stabilization. The vascular tank has been refilled, but the underlying leak has not been definitively stopped. Normalized vitals provide a temporary tactical window. However, the presence of Kerr sign combined with left upper quadrant trauma highly predicts a solid organ injury that requires immediate investigation while the patient is stable. You now face your next critical decision point, selecting the correct diagnostic tool for a trauma patient whose hemodynamics have leveled out. Because her blood pressure is currently stable, a computerized tomography, or CT scan, of the chest and abdomen is the gold standard non-invasive method for evaluating solid organs. The examiner then presents the next prompt. What does the CT show? You must correctly identify the structural organ failure, a fractured spleen. Beyond the laceration itself, there is a secondary critical finding. A hyperdense hematoma surrounds the organ, proving that active intraperitoneal bleeding has occurred. These radiological findings perfectly correlate with the earlier clinical evidence.
The ruptured capsule explains the left upper quadrant tenderness, and the resulting free blood explains Kerr sign. The CT scan provides a precise anatomical map of the injury. However, a scan is merely a static snapshot of a single moment in time. The patient's ongoing physiological response will dictate your ultimate treatment path. Upon returning to the emergency department, the patient's clinical picture drastically changes. She becomes increasingly agitated, her vital signs crash, blood pressure plummets to 80/60, and her pulse spikes to an extreme tachycardia of 130 beats per minute. This specific pattern, stabilizing after an initial fluid bolus only to deteriorate again, classifies her as a classic transient responder. The initial fluid bolus temporarily masked the underlying physiology. The active splenic hemorrhage is now severely outpacing your fluid resuscitation efforts. The examiner sets a trap, asking, "Are there any alternative investigations to CT now?" Attempting to send a deteriorating, unstable patient back to the CT scanner is a fatal exam error. The CT suite is physically isolated and lacks immediate surgical resuscitation capabilities. For a crashing trauma patient, it is widely known as the scanner of death. At this stage, the only acceptable bedside diagnostic adjuncts are FAST, focused abdominal sonographic technique, or a diagnostic peritoneal lavage.
The FAST exam rapidly confirms the presence or absence of free blood in the peritoneal cavity, and crucially, it is done without ever leaving the resuscitation bay. With ongoing hemorrhage confirmed, the definitive next step is unarguable. You bypass all further imaging and take the patient directly to the operating room for an exploratory laparotomy. Hemodynamic instability that is unresponsive to a fluid challenge definitively overrides the need for anatomical imaging. It mandates immediate surgical hemorrhage control. Your immediate surgical plan upon entering the abdomen is to perform a midline laparotomy. You will pack all 4 quadrants to temporarily halt the bleeding, allowing you to directly assess the grade of the splenic injury. You must explicitly state the primary surgical dogma to the examiner. Whenever possible, the spleen should be conserved, and minor tears should be repaired. However, in severe trauma, if life-threatening hemorrhage continues despite packing and repair attempts, a total splenectomy becomes unavoidable to save the patient's life. Removing the organ carries a severe physiological consequence. It eliminates the body's primary mechanical filter for clearing encapsulated bacteria from the bloodstream. This creates a catastrophic long-term risk for the patient, a condition known as overwhelming post-splenectomy infection, or OPSI. The examiner's final prompt targets this exact vulnerability, asking what special requirements the patient will have postoperatively. To mitigate the risk of OPSI, you must initiate a strict protocol consisting of 3 highly specific, targeted immunizations. You must list the 3 required bacterial vaccines for the examiner: pneumococcus, Haemophilus, and meningococcus. You conclude your answer with the final, non-negotiable directive for her long-term survival: the prescription of lifelong prophylactic antibiotics. Achieving a passing grade in this viva station requires proving you can manage the immediate mechanical threat of hemorrhage while simultaneously anticipating and preventing a lifelong immunological vulnerability.